Well, thank you. It's a pleasure to be here. I want to thank Drs. Hall and Ketchum for inviting me here. I don't get to come to that many undergraduate universities, and so it's always a pleasure to meet with the students and talk to the people here. I'm going to talk about our work at Boston University and the VAs in Boston. It's work that we've done fairly recently for the last 8 years or so. It's been a long journey. It's been a really wild journey for me. I would never have predicted this is where my career would have ended up. It took a hairpin turn sometime in around 2008, and I've never looked back. It's really been a very exciting time, and I work with just a terrific group of people, I think we're really getting someplace. But I just thought I'd figured because you're undergraduates, I'd tell you the story of my life in just a couple of slides. So I'm going to talk a lot about football and the negative effects of football on the brain. I'm going to talk about other sports as well. But I don't want you to think it's because I don't like football. I grew up with football. In fact, I was exposed to football at an extremely young age. I was the fifth of 5 kids. I was about 7 years younger than my next older sibling, and I adored my older brothers. And here they are, and you can see that I was a lot younger. They pretty much tortured me as a child, and when they played football a lot, and I played football too because I wanted to be just like them, and they referred to me very endearingly as their tackling dummy. Anyway, but they were my heroes that I grew up with, and if I hadn't been born a girl, I'm sure I would have gone to follow them into football as well. My brother, the number 22, became a doctor, and that's why I became a doctor. I did follow in his footsteps, but I never forgot my love of football, and this is just showing you my dad, my dad played football for Grinnell College, and I grew up right outside of Green Bay, Wisconsin, and that may not mean much to you being from North Carolina, but in that part of the country, you're basically, given a chip at birth. They put a chip in your brain at birth, and from then on, no matter what you do, you're a football fan and you're a Green Bay Packer fan, and that's definitely me. When I was growing up, I thought the biggest heroes in the world were Green Bay Packer football players, not presidents or world leaders. It was, being a Green Bay Packer. So. That's where I grew up, and that was my childhood. So back in 2009, when I was asked to talk to the Congress about head injuries in football, it was ironic to me that a man sitting in the courtroom was this man right here, Willie Wood, and I remembered him vividly from my childhood. He played for the Green Bay Packers. He was very, very, outstanding player. And I actually went over to introduce myself to him, and it was clear at the time that he was, very severely cognitively impaired, and that sort of brought home, sort of full circle, this whole line of work. Anyway, I went on to medical school. I became very interested in the brain and eventually trained with some superb neurologists at Cleveland Metropolitan General. This is my teacher, Dr. Morris Victor, a famous neurologist who was married to Dr. Betty Banker, a famous neuropathologist. And because they were married, part of our training was neuropathology. So my last year of my neurology training I spent with Dr. Banker, and I think I might have told some of you today, she was the toughest teacher I've ever had in my life. Nothing made her happy. When we dissected a brain, we always did it poorly. When we, looked at a case and came to a conclusion, we never quite did it well enough. She was a very, very tough taskmaster. And what it taught me as I went on later in life is that sometimes the toughest teachers, the ones that actually ask the most of you, are your best teachers. So. Anyway, at the time, I didn't appreciate her, and I couldn't wait to get out and do something else. And so I went on to be a fellow in neurology, but I found as I was out in the world looking at patients that I really wanted to understand what was going on in their brain and understand what the reasons were behind their symptoms. And so I went back and asked my teachers if they would recommend me to go to Harvard and train under Dr. E.P. Richardson and Dr. Hedley White, the two two neuropathologists they considered the best in the world. And so I ended up going there, and there I was surrounded with some greats, some true giants in the science and the field of neurology. C. Miller Fisher, just a brilliant man, and also Raymond D. Adams. These are some of the premier neurologists of our time, and I had the extreme honor of working with them. And what we did every week as part of our exercise in learning neurology and neuropathology was we would present these things called clinical pathologic case series, where we'd present a case, we'd go through all the clinical symptoms, and then we'd present the pathology. And that would allow us all to sort of discuss the case and learn from the case and learn why the person presented this way and why they had those symptoms. And I like to think of the work that I'm doing now as really an extension of this very classic way of training or teaching, and that is a clinical pathological case series. And I'm going to show you what we've found looking at the brains of athletes as well as military veterans, and really what we've found in terms of linking up the symptoms of this disease that I'm going to talk about, chronic traumatic encephalopathy, along with the pathology of the disease. So I started out looking at the brains of human beings some 25 years ago. I was very interested in aging as well as dementia, Alzheimer's disease. And as part of that study, I looked at the brains of many thousands of people, including the individuals from the Framingham Heart Study. And that's a longitudinal study based right outside of Boston that studies cognitively, normal people in large part, and it followed them through life until they died, and some of them would donate their brain. And I found from sort of an obsessive interest in the tau protein in these brains that no matter how old you get, 80s, 90s, 100, you really don't have very much tau buildup in the brain. You can sometimes see some small areas of tau buildup in the medial temporal lobe, but for all intents and purposes, this protein does not develop with aging in the brain. So when I came across this case, and this is a case that's prepared identically to what I just showed you, and all the tau protein that is staining is this brown discoloration, and you can see that the whole brain is practically turning brown. When I looked at this case, I was sort of blown away by it. I'd never seen anything, I'd never seen a disease of this severity and in this pattern affecting the brain, and so I became extremely fascinated with it. When I looked at it microscopically, it had this very abnormal pattern that I'd never seen before, where the pathology, the tau, the brown staining inside the nerve cells was concentrated on a small blood vessel. That's quite unusual in neurodegenerative disease. In fact, there's no other neurodegenerative disease that shows that pattern. And then the second thing that was fascinating about this disease was it was very patchy, it was very irregular, and it was mostly concentrated at what we'd call the valleys of the brain, or where the cortical sulcus dives in. We'd see a whole patch of pathology there, and then you'd go to other areas of the brain and then wouldn't see so much pathology. So that very patchy distribution was quite unique. And it turned out that this was actually a professional boxer, the brain of a professional boxer named Paul Pender. He'd been world champion twice over, was very well liked in the New England community. But his story was that he'd boxed until he was about age 33. He retired, he was fine, and then 20 years later, in his 50s, he started developing symptoms. He became very paranoid and irritable and agitated. He started being physically assaultive with his wife and his children, but he was also losing his memory. And so the doctors who evaluated him at that time thought he had Alzheimer's disease. And so he was followed for several decades with the diagnosis of Alzheimer's disease until he died at 73. But of course, looking at that brain that I showed you a minute ago, that is not Alzheimer's disease. It's an entirely different pattern. And in fact, one of the proteins that we find in Alzheimer's disease wasn't present in that brain. And then a couple years later, Bennett Amalu described some changes in a football player, which he described as chronic traumatic encephalopathy. And I became interested in looking at football players' brains, but I never really had the opportunity until I met Chris Nowinski, and I think some of you are familiar with him. He's a very dear colleague of mine. We work together very closely. But it was really meeting Chris Nowinski that changed the trajectory of my career. Anyway, Chris was a Harvard graduate. He played football for Harvard. But then, unlike all his other classmates in history, he went on to be a professional wrestler. And he fought under the moniker Chris Harvard, and he'd come in wearing these crimson shorts with the H on them, and quoting Shakespeare, and that would irritate all his potential opponents. And that was his whole shtick. But Chris found, even though he was only in his mid-20s when he's doing this, that he was having terrific headaches. And debilitating nightmares. He'd find himself literally crawling the walls of his hotel rooms. And the thing that was most disturbing to him, even though he's such a young man, he was having memory lapses. And so he went all over the country trying to find a doctor to diagnose his condition and tell him what was going on. And he went to 8 different doctors throughout the country. And it wasn't until he met Dr. Cantu, who was another doctor that we work with out of Emerson Hospital right outside of Boston, that Dr. Cantu took a very careful history and said, you've had 11 very serious concussions, and you're at high risk for long-term brain damage. And he recommended that Chris give up professional wrestling. And of course, Chris, because Chris is Chris, he didn't give it up right away. He's a very stubborn guy. But eventually, he did give it up, and it really became his mission to try to understand these long-term consequences of head injury that he'd suffered during wrestling, but that occurred in other sports. And it was really Chris that became very influential in my career in helping us get brains from athletes and families of athletes to donate their brains. So the first football player that I was able to examine was a guy named John Grimsley. And what had happened was he was a 9-year veteran of NFL. He'd retired at 32. He had a wife and a family. He was employed as a hunter and guidesman. And actually what happened is he was cleaning his gun one day, and it went off accidentally and shot himself in the abdomen, and he died. And so his wife, Virginia, had been a little concerned about him. She'd noticed over the last 5 years that he just wasn't quite the same guy she married, that he was just not able to keep track of things. He couldn't remember things when he went to the store. He kept renting the same video over and over. But the incident that really bothered her was that their son had come home one day and said he was engaged to be married and started telling him all the plans they were making for the wedding. And by the evening of that very same day, John couldn't remember that his son had told him he was getting married. So Virginia was concerned about him, and because of those symptoms, she wanted us to look at his brain. And we did, and this is his brain in this middle panel. And it's at the level of the amygdala. And the amygdala, as you know, is a part of the brain that's responsible for rage and emotionality. And you can see that John Grimsley's brain, even though he's only 45, which is a tremendously young age to have a neurodegenerative disease, he's got tau pathology throughout his amygdala. He's got a lot of tau pathology in his temporal lobe. And actually, the pattern of the lesions, the pattern of the pathology is very similar to what I found in the boxer's brain, only the boxer lived another 30 years. And what it suggested to me was that if John Grimsley had lived another 30 years, he would have become very severely demented and very severely impaired, just as Paul Pender had. So we wrote up these very early cases. We had 3 cases back in 2009, and we decided to review the world's literature. And just to show you where we were in 2009, there were only 48 other cases that had been described. So this is a relatively rare condition. But it had been described back in the 20s in boxers. It was first described by a man named Harrison Martland. Even though he was a pathologist, he only talked about the clinical symptoms that he said affected nearly half of the boxers who stayed in the ring long enough. So at first it was called punch drunk because the guys with this condition looked like they were drunk, and then later it was called dementia pugilistica or dementia pugilists. And then later in about the 40s, it was called chronic traumatic encephalopathy, and that was to sort of highlight the fact that this is a disease that is a consequence of trauma, but the trauma really doesn't have to be boxing. It can be any trauma from any source as long as that you have a sufficient exposure. So what we did back in 2009 is we built a brain bank, and we started really trying to collect brains from individuals who've had these mild traumatic brain injuries. And over the years, we're now up to about 230 cases, and you can see that there have been another number of visitors to the brain bank. There's been a lot of interest in this brain bank, and it's some of the cases that have come in through this center that I'm going to show you tonight. Just to show you where we've come since 2009, we had 3 cases, and if you totaled that with the world's experience, there were 51 cases, and now at last count, because this number keeps rising, we just at our center have 131 cases of CTE. So this is this is a very skewed population. It's an autopsy study. There's no way this reflects the incidence and prevalence of this disorder. It says nothing about how common this disease is in living individuals or people that have played this sport. All of those are really important questions, but they'll have to be answered by other studies. What our study shows is that this disease occurs, that it exists. It's told us a lot about what the symptoms are and what the pathology is, but there's still many, many unanswered questions, like how does a concussion or subconcussion lead to this disease? How many concussions is too many? Or how many subconcussions is too many? That is going to require other studies, and a lot of them are going to be longitudinal prospective studies that'll take probably decades to completely resolve. This is sort of the initial volley. This is the volley that says we've got a problem. We're not sure exactly how big the problem is, but we're starting to understand what the problem is. You'll notice that there are a lot of football players that have come into the brain bank, and those are football players at all levels. We've had 79 professional players come in, and 76 of them showed CTE. We've also had college players and high school players, and I'll show you some of those examples later. But we've seen boxers, we've seen rugby players, we're seeing increasingly soccer players, and we also see military veterans. So it's an equal opportunity disease. It really depends on the amount of head trauma. What are the symptoms of this disease? And they tend to be sort of take two broad categories. In individuals that show symptoms early in life, that is in their 30s, it often presents as a behavioral or mood disorder. So it can be easily misconstrued as a psychiatric issue or midlife crisis or maybe an adjustment reaction. But it's actually a physical ailment that gives rise to some personality changes and behavioral changes. And those changes tend to be things like impulsivity, quickness to anger, like a very small infraction will cause sort of an exaggerated anger response. A lot of aggression, there's assaultiveness, you can see attention and concentration loss. There's very often mood changes, which are predominantly depression. And it's also in this group that we have found a lot of suicidality. You'll see that there are a lot of individuals who've taken their own lives. We see a lot of drug and alcohol abuse, as well as short-term memory loss. If a person presents later in life, usually in their 50s and 60s, then it can look, at least in the initial stages, very much like Alzheimer's disease. If you didn't know they played football, you might not be thinking about this disease. It looks like a memory loss. They can have what we call executive dysfunction or poor planning. And as it becomes more and more severe, they become completely demented, not able to think clearly at all. And usually these two different groups sort of mix as the person continues with his disease. The disease is progressive. Once the symptoms are triggered, they continue to progress as long as the person survives. We've also described in our work a subset, a small group of people with CTE that have a motor neuron disease that looks completely indistinguishable from ALS, and in fact would be called ALS, and I'll talk about that in a few minutes as well. So the pathology, which is what I do, is very distinctive. It's not Alzheimer's disease. It's not any other disease. It has a very, very distinct profile. I'll show you that there are changes that go on in the brain. You usually can't see these structural changes in the brain until the disease is very advanced. So if you had a young individual with CTE, you're not going to see these structural changes that I'm going to show you. They come on with very advanced disease. But the change that we see most, which is classic for the disease, how we make the diagnosis, is these abnormal deposits of tau. It's an axonal protein in the brain that becomes abnormally phosphorylated. It falls off the cytoskeleton where it normally resides and starts clumping up as this toxic fragment in the nerve cell. And it accumulates both as neurofibrillary tangles inside the nerve cell and as all these disordered neurites in the neuropil. There's also other changes in the brain. I'm not going to talk about those so much today, but we also see buildup of another protein called TDP43. We see tremendous change to the axons, or the white matter in the brain, the fibers connecting the nerve cells. And we see a lot of neuroinflammation. And I don't want to shortchange these changes. They're very, very important changes, but I'm not going to talk about them today because they're not how we make the diagnosis primarily. This is just to emphasize that it's not just tau protein in these brains. There's also considerable white matter damage and fiber damage, damage to the axons. So what are the changes that we see grossly? What we see are changes in the septum. The septum is usually dividing the ventricles in half. It's a single leaflet ordinarily. But if you have repetitive brain trauma, you can get a duplicate membrane. It splits apart, and you get what's called a cavum septum pellucidum. So that is one clear stigmata of trauma that we see in this brain. We also see dilatation of these interior chambers called the ventricles. So they're containing the CSF. They become very abnormally dilated. And especially this third ventricle, which is interior to the thalamus. The thalami are on both sides of this ventricle. And there's a lot of thalamic atrophy in this disease as well. We also see medial temporal lobe atrophy, and this is important for the memory loss and the learning problems, because the hippocampus is the seat of memory in the brain, and we see extreme shrinkage of the hippocampus in this disease. We also see things like fenestrated septums. That is, the septum has become so damaged that it's only strings or sometimes completely absent. And we might see other changes. This is actually just showing you a different former NFL player with a different fenestration, a single large perforation, and we can also see multiple septal fenestrations. So different varieties of damaged septums in these individuals. And we also see pallor of the nigra, and those nigral neurons are responsible for Parkinsonian symptoms. That is, if those neurons are dying off or degenerate, that's where we get Parkinsonism. And you do see degeneration of that part of the brain in this disease. If we were to look at two coronal sections, slices of the brain side by side, one from a normal person and one from a person with CTE, and this is just putting the slides on a photoscanner, not even using a microscope, you can see these areas of brown pigmentation quite easily in the brain affected with CTE. And so this is what it looks like, and it's extraordinary degeneration. It's very patchy, as I said before. It tends to favor the depths of the sulci, and it favors regions of the brain that control emotion and memory, like the amygdala, the hippocampus, the mammillary bodies. It's really quite an extraordinary disease that's florid when you see it in these individuals. And it also affects substantia nigra, again, the Parkinsonism, and locus coeruleus, which a lot of people think has to do with the development of depression in a number of these people. The two features that distinguish it from all other diseases are, the first thing is that it's perivascular. It's around blood vessels. So there's something about the leakiness of the blood vessels that happens after trauma that probably gives rise to this disease, but we still don't quite understand it. So it's perivascular. That's a very key part of the pathology. And the other thing, like I've mentioned several times now, it's patchy and irregular, and it tends to form at the depths of the sulci. It's not Alzheimer's disease, and I'm going to emphasize this only because so many people, even in the medical literature, think this is Alzheimer's disease, and it's not. It's very distinct. First of all, Alzheimer's disease has to have beta amyloid plaques. They're showing up in this section as these red areas. In most cases of CTE, there's no beta amyloid. We don't see it ever in the early cases. In fact, we only start to see beta amyloid with aging. So the earliest we see beta amyloid in the CTE cases is age 50 and older. And then if you just looked at the pattern of tau, just to bring this point home, even if you just looked at the tau pattern, you can see that CTE, even if you're not a neuropathologist, this is a very irregular, very patchy distribution of abnormality, whereas something like Alzheimer's disease is very diffuse and it tends to symmetrically involve the brain. So very distinct diseases. One thing that we're not clear about is what the relationship of this disease is to the traumatic injury, the concussion, and what we call subconcussion. Concussion and subconcussion are acceleration-deceleration injuries. They're when the brain is violently rocked back and forth, either in a linear fashion or in a rotational fashion. And both of those forces are probably equally important. We know the only difference between concussion and subconcussion is that concussion is symptomatic. So the same hit in a different person may cause symptoms, and another person, no symptoms. Same impact, same injury to the brain, but one is symptomatic. That's the only difference between concussion and subconcussion. And why we think it's important is that there are certain sports, certain activities that have a lot of subconcussive injury, and that's becoming more and more evident in football. It's been estimated that a single lineman will have between 900 and 1,500 subconcussive hits per season. So you can imagine if a person plays football for 10 years, we're talking tens of thousands of hits. And increasingly, it's recognized in other sports. Not just boxing, but soccer. In fact, there's a lot of focus now on heading in soccer and the subconcussive injury that occurs in soccer. Let's see. We're not exactly sure what the relationship is. I can show you that this is what the injury is, the mild traumatic brain injury. It's just a little monograph showing you sort of the very simplistic vision of it. But what you have to think of is the brain is pliable. The brain is like a firm gelatinous substance. And when you're getting these forces, either front and back or rotational, the brain is actually stretching. Sort of like silly putty, if you will. And the things that are the elements of the brain that are the longest, that stretch the furthest, are actually damaged the most. And what are those structures? Those are the axons, which sometimes go from your brain to your spinal cord. They can be about 3 meters long. And the blood vessels. Those are the two elements in the brain that are especially susceptible to this concussive injury. We can see the changes of concussion at the electron microscopic level. This is an axon in black, and you can see these blebs indicating this axonal injury. And when we look at some of the athletes that die after a concussion, we also see this axonal injury, which shows up on what we call an APP immunostain. But you can see these dilated abnormal axons in individuals who've died after a concussion, and you can see that more of these dilated axons are around the vessels. So there's something about the perivascular sort of brain that's more susceptible to injury. We also see a lot of inflammation after concussion, and in some of these young guys, because these are mostly teenagers, we can see just the beginnings of this abnormal tau deposition. What we don't know is if this abnormal tau deposition, when it's so early on, is it possible that it could be reversed? Could this go away with rest? That's a question that we don't know, but that's sort of one of the ideas behind resting your brain after a concussion. You want your brain to go back to baseline, or as closely to baseline as you possibly can, because you don't want to re-injure your brain on top of an injured brain. That's what we think actually causes or provokes or triggers this long-term neurodegeneration. It's injury upon repeated injury that triggers in some susceptible people this disease called CTE. There has been a lot of debate about whether this is caused by trauma. I think there are a lot of people that would like to pretend this isn't caused by trauma. And I'm limited because I look at human beings. I can't ask someone to get hit over the head and then die for me, so I can figure out if this is really related to trauma. I have to rely on animal models and circumstantial evidence. And we can do those things, but again, it'll require time to absolutely prove definitively that this disease is caused by trauma. But I like to put up this quote by Walter Koroshetz, the deputy director of the NINDS, and it's like, people, there's some things we don't know about this disease. We don't know when it starts. We don't know what other factors are involved. But let's face it, this is due to trauma in the brain, which is where I am. I'd also like to explain what evidence we do have that it's trauma. And I think we can explain where the lesions are in the brain by where trauma affects the brain. And there's work, biomechanical work by Klutz and colleagues, that when they subject the brain to shear injury or shear force, the greatest abnormality of these forces, the greatest amount of shearing force, are at the depths of the crevices of the brain. And you can actually sort of take this home, like when you open potato chips or a candy bar and you've got that serrated edge. When you crack it open, it always cracks at the bottom of the crevice. And that's why we think the tau pathology is centered there. It's because that's where the brain experiences the greatest mechanical injury. And then we also know that the interface of tissue of two different viscoelastic properties, like blood vessels and brain tissue, that's where you're going to see the greatest shearing force as well. And so that would explain why we see the abnormalities around blood vessels. We also know from work in animal models, this is a miniature pig. A miniature pig is gyrencephalic, which means it has all those hills and valleys like the human brain. Rat brains, those are smooth brains, so we're not going to see these changes in a rodent brain. But in a miniature pig, when you subject them to this acceleration-deceleration injury, you see changes at the depths of the sulci, which is exactly where we see the changes in the human brain. And we also know from the forensic literature that some people that are hit in the head with a hammer and other horrible traumatic injuries, that we see the greatest changes at the depths of the sulci. So all of that is evidence that this is a trauma-induced disease. So now I'm going to show you some examples. This is what our experience is in athletes so far. And some of these numbers aren't completely up to date because it's a running tally. But I'm going to show you that we've seen a lot in football players. And as I said before, about 96% of the NFL players have this disease. We also see it in Canadian football players, semi-pro players, and a lot of college players. I think, disturbingly, we're seeing it in more and more college players. We've seen also early stages of this disease in high school players, as well as other sports. And if we were to look at a montage of what some of these athletes have looked like, because this is a human disease, it's not an experiment, it's not some theoretical model. This is actually what I'm showing you are actually human beings, and their families are very, very interested in you knowing about them and you seeing their picture. It's unlike most medical research where we have to maintain privacy. We've had, everything has been signed off by the families. They want you to know what their loved one's gone through. So this is just a montage of some of the athletes that have donated, whose brains have been donated to the center, and it's pointing out that some of these are very young athletes, high school athletes, college-level athletes, NFL athletes, hockey players, boxers, many individuals who have taken their own lives, and not very many, but a few female representatives. We're always trying to get more females in, but the demographics of the injury so far has favored a predominantly male population. Anyway, those individuals, if you were to look at their brains and compare them in the same way, when you see very early CTE, it shows up as just a couple of spots in the brain. As the disease gets worse, it shows more and more of these spots, these areas of abnormality. Eventually, the spots start fanning out. They start fanning out and affecting the neighboring cortex, and they start to become more numerous. And then as the disease continues to progress, there's more and more of the brain involved. You start to see confluent areas in the medial temporal lobe, and eventually the disease affects the entire brain, and often brainstem and even spinal cord. In one of our publications, we divided this into 4 stages, with first stage being the earliest or most mild, and 4 being the most severe. And I'm just going to show you some examples. So this is a high school athlete. His name was Eric Pelly. He died 10 days after his 4th concussion. Very, very surprisingly, we found in his brain these very abnormal spots. This is tau protein centered on blood vessels in his frontal lobe. And if you look carefully, just to show you what that lesion looks like, here's the blood vessel, and here's the abnormal collections of tau in the nerve cells around the blood vessel. Very, very abnormal. You know, an 18-year-old brain is still developing. It's still maturing. It's laying down fiber tracts. It's pruning synapses. It's developing. And here we have an 18-year-old whose brain is not even fully developed, and he already has areas of very, very severe neurodegeneration. There is no way that this is a normal finding. An 18-year-old brain should be absolutely pristine. So even these very small areas of abnormality are extremely unusual. Here's a college football player, and this is a case we had recently. His name was Michael Keck. He played for Missouri. He played 3 years of Division I football as a linebacker and special teams player. And while he was playing football, he had a number of concussions. And he was developing problems with vision and memory, difficulty with sleeping, and headaches. And actually, he was concerned about himself, and he was talking to his coaches about how he wanted to be, he didn't think he was ready to go back and play. Anyway, he eventually ended up quitting the team and leaving college. So he only played 3 years. But even though he no longer played football, he had continuing memory losses, problems with attention concentration. In fact, his symptoms kept getting worse over the last 18 to 24 months of his life. He also had some depression and impulsivity problems. And then, very unfortunately, he developed a staph infection and died. And his wife donated his brain to our center. And this is showing you Michael Keck's brain. So 25 years old, played 3 years of Division I college football. And you can see these extreme areas of abnormality in his brain in the very classic pattern that you're going to see, the CTE, the depths of the sulci. It's only tau protein. There's no evidence of any other disorder. This is CTE. We've seen it in hockey players. I'm not going to belabor the point. This is Derek Boogaard, who is well known as an enforcer for the NHL. He played, his career stats were 3 career goals and 589 penalty minutes. So it gives you an idea, you know, what his job on the team was. He wasn't a skill player, as I understand it. But anyway, he died of a drug overdose, OxyContin and alcohol. And he, too, had these lesions of CTE in his brain. More severe cases of CTE we've seen in older individuals like Dave Duerson, a very well-known Chicago Bears player, played for 11 years. He's known for the fact that he was a very skilled football player. And then after he retired from the NFL, he was very, very successful. He ran a very successful food company called Duerson Foods. He had a wife and family, 4 kids. And I think, ironically, he served on the NFL Players Association Benefits Board. And what a lot of people remember about him is he denied benefits to people that were coming to the board saying that they were experiencing memory loss and some cognitive issues, which they felt was from football. And he was very much against that idea and denied benefits to those people. But then some 5 years later started developing problems of his own, memory problems, vision problems, had trouble finding words, and then very disturbingly, very physically aggressive with his family, assaultive with his wife, his kids, very, very different personality. And he's the person that texted his wife and told his family that he would like his brain donated to the NFL Brain Bank before he took his life by shooting himself in the chest. And so we received the brain of Dave Duerson, and lo and behold, we also found the same changes in his brain that we'd seen in the other players. More severe than the others that I've shown you, but no other disease in that brain. No evidence of Alzheimer's disease, no Parkinson's disease. This is pure CTE. And then just to show you what it looks like in very advanced stages, this is a rugby player. When I went to the International Concussion Conference in Zurich. I got a lot of heat from people in Europe because they felt this was an American disease. This is something that really only happened to American football players. It didn't happen to soccer players, and it didn't happen to rugby players. And so this is a case in point that it can happen to anyone who has a lot of head trauma. This was a player by the name of Tizza Taylor. He played rugby all his life, and his history was that he started having problems in his 50s. He became demented and very physically and verbally abusive in his 60s and died at the age of 77. His brain showed all the gross changes of CTE, the tremendous ventricular dilatation, the changes in the septum, the shrinkage of the hippocampus, and microscopically just severe changes of CTE throughout the brain. We've also seen this is why I went to Brazil about a month ago. I was able to see the brain of Bellini, who was a very famous soccer player in Brazil. And he had died with dementia, which many people thought was Alzheimer's disease, but it turned out to, in fact, be CTE in his brain as well. So it's just pointing out it's just not American football players. It's really any sport or any activity that can, where there's a lot of brain trauma. We've also seen in military veterans, I'm not going to talk about this very much, mostly the young veterans from Iraq and Afghanistan, blast injury. It's associated with blast injury in these younger folks. And the pattern of injury looks very similar to what we see in the athletes. In fact, it's very much perivascular in those people as well. And then last but not least, I was just going to talk about this motor neuron disease, or the ALS. We first reported it in 2010 in association with CTE. We got a lot of heat after that. The headlines came out that Lou Gehrig died of concussions and all sorts of things, and the ALS doctors were very upset with us. It was actually a very uncomfortable time. But the one good thing, or several good things that happened after that, was I got a call from I'm going to skip to Ron Perriman. And Ron Perriman had been diagnosed with ALS at Mass General Hospital. And he called me up on the phone and he said, "Doc, I've been reading about your study, and I just want you to know that I think I have what you're describing, because I was a player for Boston College. I played very, tough tackling football. I had a lot of head injuries, and I think those head injuries are what are related to my ALS." And so he invited Chris and me down there to visit with him and his wife, and here we are visiting with Ron. Ron's clearly he's disabled at this point. He could still speak quite well, although he would tire easily, so he could tell us his history. This is his wife, Amy. And he told us his story, and his story was that he'd played football since he was 8, had a lot of concussions even in high school, a lot in college. He even fractured his neck playing college football and played to the end of the game, but then later had surgery. And then at age 37, he developed weakness in his left arm. At age 38, he's diagnosed with ALS. And he dies. And then at age 40, his wife noticed some very subtle cognitive problems, disinhibition, sort of inattentiveness, not difficult things to describe, but just a little different than his usual self. And so then I got another call from Ron Perriman about 4 months later. So he calls me in September, we go down and visit, and then he calls me again in January. And he said, "Doc," and he can still speak, which is unusual, and he says, "Doc, I just want you to know I'm having a big party. I've got all my friends here. I've got my football teammates. I've got my doctor. We're all celebrating because I've decided I don't want to stay on this mechanical ventilation. I'm going to wean myself off of it tonight. And the doctor doesn't think I'll make it through the weekend. So I just want you to know that, I want you to have my brain and spinal cord after I die." And, for a pathologist, this is quite extraordinary. I don't know if I've ever had a patient say that to me quite so clearly. I said, "Of course," and then the next day, Ron died. And so we went down, we got the brain, and we brought it back, and we looked at it, and this is Ron Perriman's brain. I mean, he was exactly right. He has those classic lesions that we've seen now in the other football players and soccer players, some involvement of the hippocampus. So this very profound CTE in the brain, but associated with a type of motor neuron disease that we think, and we're in the minority there, is related to the trauma. We've seen it in soccer players. Someone asked me about this case earlier. This is a young soccer player, played soccer exclusively all his life, was known as a header. He loved to head the ball. And then he developed ALS at the age of 27 and died at age 29. And his parents donated his brain. You can see this is just the gross sections of his brain. You can see the shrinkage of his frontal lobes. He's only 29. This is quite extraordinary. But if you compare it to a 65-year-old man's brain, you can see that his frontal lobes are really quite small compared to this normal brain. And then when we looked at it microscopically, we could see these abnormalities of tau throughout the brain. And again, they're very much perivascular. They're centered on these small blood vessels, so it's the same disorder. Now we have about 13 cases of young individuals who've developed ALS, and extraordinarily, 4 of them developed this disease in their 20s. And we also know that there are 6 living NFL players who have been diagnosed with ALS. Some of these guys have been very active in our work. Steve Gleason, Kevin Turner, Steve Smith, but 6 guys so far. Young, and most recently Tim Shaw at the age of 30 developing ALS. So this is an issue that I think we need to address, and I think we need to address it urgently, because we don't want our young athletes and our young military vets developing this unbelievably debilitating and fatal disease. So just to summarize what I've shown you so far, we don't know a lot. It's an incomplete science. It's as far as we can take it with clinical pathological case series. We can understand the pathology, we can get a better idea about the clinical symptoms, but we can't answer a lot of the questions that are really important. We know that it's a chronic degeneration that occurs in athletes and military veterans. We know it's not normal aging, it's not Alzheimer's disease. And we know that once it's triggered, which usually, at least the symptoms tend to come on years after the person stopped playing the sport. They don't develop them usually right while they're playing the sport. Sometimes they do, but not usually. It's usually years later, even 10 or 20 years later. What we really need to develop is a way to diagnose this during life, and there's a lot of research labs all through the country working on this with blood and CSF and saliva. We need to understand why some people get this disease and some people don't. Why are some people at such high risk for this disease and other people don't seem to be as affected? We need to know how common this disease is, especially in the different sports. What are the risks to football players? What are the risks to soccer players? We don't know these things right now. And we don't really understand the mechanism, the pathogenesis of this disorder, how repetitive acute trauma leads in some people to this progressive degenerate cascade, which continues to progress as long as the person lives. And then we think they're definitely genetic and other environmental factors, but we're still trying to figure out what those are. We've got a lot of research going on. I'm just going to show you some, really just sort of a blitz of what the research involves. Animal modeling will be very important for solving some of these questions, for resolving some of these issues. Lee Goldstein at BU is working on a blast model, but he also has a concussion model. We found similar changes in mice, but much more work needs to be done. At our center, we also have the beginnings. Actually, there's a big UO1 out for a well-designed longitudinal prospective study of athletes in controls sponsored by NIH. Those grant proposals just went in, so it'll be very important to see who gets that grant. We did apply from our center. I'm not sure if we'll get it. But hopefully there will be one of these longitudinal studies that will help address a lot of these questions. There are a lot of centers looking for a way to diagnose this during life using PET imaging, especially this ligand called T807. We're using it in our young military vets at the VA. We're also looking in retired athletes, both at Mass General and at the Brigham and Women's. We're looking at eyes because we're seeing a lot of pathology at the back of the eyes in people that have developed CTE, and we're hoping that maybe that can lead to a way to diagnose this disease during life by doing an ophthalmologic exam. We're looking at different components of the biochemistry, like when a person develops the beta amyloid, which isn't at first, but sometimes with aging. Torstein is doing some terrific work at my center showing that Beta amyloid sort of fuels the fire. It makes the course works. It makes the clinical symptoms more severe. And it also promotes the development of Lewy body disease and Parkinsonism. So I think it has some important implications about the prognosis if beta amyloid is eventually deposited as well. Other people are doing molecular and genetic investigations, like John Crary that works with us from Columbia. And we have a UO1 on the pathology, and that's my study. We got a recent grant from NIH to study the pathology. We have 3 goals, which are to define the pathological criteria, to nationalize the brain bank so that more people will be doing this kind of work, and to develop neuroimaging tools. And we have a big conference coming up in February where some of the best neuropathologists in the world, these are the people in yellow, are like world-class neuropathologists, and they're going to be looking at cases blinded. They won't know what the histories are, and they're going to see if they can diagnose CTE, and hopefully that'll put to rest the idea that this is not a distinctive disease and this is just decorative artifacts, which have been, or some of the labels that people have given some of my work. Anyway, there's a lot going on with lots of research at our center, but all over the country. I just want to urge you to, if you have any interest, to please participate, because I think we owe it to this young population of individuals who are susceptible to figure out this disease as quickly as possible, figure out ways to treat it. This takes a lot of people very committed to do this work, as well as the families. People at my center, as well as Lee Goldstein and other institutions. And I have to thank the people who fund us, which is the NINDS and NIBIB, the Veterans Hospitals, the Veterans Affairs, the Department of Defense, and we have some philanthropic support from the Andliger Foundation and the WWE. So thank you very much.